Good morning, good afternoon, good day, wherever you are. Welcome back to our second panel here. And some of you may be wondering, why are we talking about HLA? So this particular session is going to be examining the role of the HLA genotyping in the therapeutic era. And we just heard from our first panel that HLA is taken out of the guidelines in Europe, and here we are talking about it. So hopefully, by the end of this hour, we'll be able to have some inroads into the reasons of why we need to do HLA genotyping. Currently, we all know that it's not part of the workflow in the routine clinical practice. What we are hoping in the next hour, we should be able to at least kind of talk a little bit about, should genotyping purely be an exclusionary diagnostic tool, or should it be a clinically actionable tool, or is it eligibility defining for the actual different therapies? The current landscape will be mapped out by the speakers, identifying areas where interpretation, documentation, test variability could create real challenges once the therapies do reach market. So what does each report verify? Hopefully we'll all learn some of that from three speakers. And of course, what safeguards are needed to prevent research criteria from being misapplied in payer coverage policies? So lofty goals, but I know that this team is just fantastic and will be able to accomplish most of this. And our first speaker here today is Dr. Ed Liu. He is a professor of pediatrics at the University of Colorado School of Medicine and director of the Colorado Center for Celiac Disease. As a pediatric gastroenterologist, Dr. Liu has dedicated his career to advancing the understanding of celiac disease with a particular focus on serology, mass screening, and epidemiology, especially in the intersection of celiac disease and type 1 diabetes. He is a founding member and inaugural council member of the Society for Study of Celiac Disease and an active member within NASPGHAN's Celiac Disease Special Interest Group. Is totally committed to expanding global collaborations in pediatric celiac disease research through NASPGHAN and RACD. I know a lot of us don't need any introduction for Dr. Liu, but those who don't know you know you now. So Dr. Liu, floor is yours.
Okay, thank you so much for the introduction, and let me make sure I get the right screen here. Okay, how about this one?
Yep, working.
Okay, so you can see that, right?
Yes.
Okay,
Thank
good.
you.
So the title of this is, about the clinical utility and the implications of genetic testing. And thank you for the opportunity to speak here. I'm really pleased to be here. My disclosure is that I'm a contributing author to Up to Date, the celiac disease section. And the objectives here that we're trying to reach is to discuss the role of HLA genotyping in disease diagnosis today, and also discuss when genotype functions as a diagnostic tool for exclusion, and discuss the potential future roles of genotyping in treatment stratification and also the pediatric considerations for genotyping. I think we are going to be looking at like a shift in how we frame genotyping. Traditionally we're looking at this as like, do I have a genetic risk? But really the question that we're going to be shifting to, especially when drugs become available, is, am I actually eligible for treatment? And so since this is the first talk on the genes, I'm going to give you just a bit of a background about the HLA, and it gets very complicated, and I hope I can explain this in a way that's more understandable. But when we look at the genes that are involved, right, if you take a look at everyone who has celiac disease and you break down the distribution of the genotypes, you say that the majority, right, 90 to 95% of individuals will have HLA DQ2. Okay, and it's more specifically DQ 2.5. And that means you've got like an alpha chain and you've got a specific beta chain there. Okay, so DQ2 is the major one. And then 5 to 10% of individuals would have HLA DQ8. And more specifically, we call it DQ 8.1, which has its own separate alpha chain and beta chain. But there's another DQ2 out there, okay, that's designated as DQ 2.2. And so 2.5 and 2.2 can both be considered to be DQ2, but the 2.2 is basically half of the 2.5 molecule. So it has only one of the chains, all right? And then you've got the DQ 7.5, which has the other half of the chain. So when we do HLA testing in individuals, it's important to be testing for all four of these possibilities, because when you combine 2.2 and 7.5 together, you could actually make a proper DQ 2.5 molecule. But 7.5 on its own is very, very low risk. Okay, it's negligible. And when you have neither DQ8 or DQ2, your chances of ever developing celiac disease is also very, very low, less than 1%. So you can consider celiac disease to be essentially an HLA restricted disease, restricted to having either DQ2 or DQ8. And nearly all individuals with celiac disease will have one or both of these genes. And that also means that not everyone with these permissive HLAs will actually have celiac disease as well. So you can also say that DQ2 or DQ8 is virtually necessary, but not sufficient. So just to put this in another way, when you look at the genes that are involved, so this is looking at DQ2. And remember, when we inherit genes, we get one from our mother and one from our father. So if you inherit the alpha chain and the beta chain together from one parent, that's considered to be inherited in cis, and that forms a proper DQ2 molecule. Okay, but you can also inherit one of the chains from one parent and the other chain from another parent, and these can also combine in trans to form a DQ2 molecule. Right. So, and then DQ8 has its own proper alpha and beta chains. Okay. Okay, so the risk of developing celiac disease, autoimmunity, and other autoimmune diseases that are associated within a general population really does vary by your genotype. So if you look at this, the risk of developing antibodies for celiac disease over 10 years, the highest risk is actually having two copies of HLA-DQ2. So if you're DQ2 homozygous, your risk is really the highest, compared to individuals who have one copy of DQ2 compared to individuals who have two copies of DQ8 or one copy of DQ8. And so you can start to stratify risk based on your actual genotype. But genotype's not the only thing that matters. Where you're born also plays a role. So this is from the Teddy study looking at sites that follow infants from birth with specific genotypes. And if in sites in Washington, Georgia, Colorado, a site in Finland, Germany, and Sweden. And let's take a look at the highest risk genotype, those who have DQ2 homozygosity. The risk of developing celiac disease by 10 years of age ranges from 9% by age 10 to as high as 28% by age 10. So it turns out that if you were born in Washington State, your risk of developing celiac disease by age 10 for being DQ2 homozygous is 9%, compared to being born in Sweden, where it's 20%. And this is true for all the genotypes where there's a wide range. So not only does your genotype matter, but also the region of where you were born matters. And what's the role of HLA genotyping in celiac disease diagnosis today? Well, we've talked about this, right? I mean, basically, HLA should not be a standard part of the diagnostic process, but there can be a role. Now, previously, HLA was required when you were trying to apply the serologic criteria for the diagnosis, meaning if you had that TTG antibody test that was greater than tenfold, you're EMA positive, you had symptoms, and you had permissive HLA, then you would make the diagnosis of celiac disease. That was the old criteria from Europe. But they took away the symptoms in HLA, so that's no longer required for diagnosis. But certainly, it can also play a role in, for example, risk stratification, like I showed you with the different genotypes. And it can tell you who's very unlikely to ever develop celiac disease. And so, HLA does certainly have a high negative predictive value, but it also has a poor positive predictive value. Now, there was a publication that came out of Gastro in 2022 that starts to allow you to stratify your own risk based on whether or not you had a first degree relative, a number of first degree relatives affected with celiac disease based on your sex, if you're male or female, and based on your HLA risk group, meaning what genotype did you have? And this, like, for example, group one, group two, three, four, five, depending on how many copies of DQ2 or DQ8 that you had. And so this is using HLA to start to risk stratify with other features. And when you input these things on their website, then you can start to look at your risk by age 10 or 12 of developing celiac disease. So there is some role in risk stratification, but mostly it functions as, for now, as an exclusionary diagnostic tool. So we use HLA at this point to kind of tell us when someone's very unlikely to develop celiac disease. So clinically, it can play a role in assisting to resolve diagnostic uncertainty, and it can play a role in avoiding, for example, unnecessary surveillance. So, for example, quote, I've always had trouble with gluten, and thus I avoid it. But I don't know if I've got celiac disease or not. Should I do a gluten challenge? So this is where HLA testing can be helpful clinically, because if you don't have DQ2 or DQ8, then your chances of ever developing celiac disease are going to be extremely low, right? And this could really affect your clinical decision making. Another scenario would be, quote, one of my parents has celiac disease, and I want to know if I have a risk of also developing it before I start to get periodic testing over time. So again, if you did not have HLA-DQ2 or DQ8, then you may not need to get repeat TTG antibody screening. From the research standpoint, we look at HLA to help us enrich our study populations, because this helps us define at-risk cohorts. And again, you can also start to use this to predict disease. So for example, there are a number of prospective birth cohort studies that only follow kids who have the permissive HLA genotypes. And the reason for this is because, again, if you don't have these HLA genotypes, you're not going to develop celiac disease. So there's no point in following them. What about the potential future roles of genotyping in treatment stratification? Well, identifying individuals who have the highest risk can help you, for example, in enrolling for actual disease prevention. For example, maybe you've got a potential intervention you want to test out to prevent celiac disease from happening, and you would only want to look at individuals who are DQ2 homozygous because they've got the highest risk. On the other hand, you'd have to look and see how common the HLA DQ2 homozygosity is. And actually, I may just skip a slide. I'll go back to this in a second. Now, you can also use the genotype to help you determine, this is really the purpose of this session, determine eligibility for drugs that may be HLA dependent. Okay, so there may be some drugs that really depend on what HLA you have, such as HLA blocking therapies or antigen-specific tolerogenic strategies, or even like T-cell receptor targeted therapies. So I'm going to go back real quick just to show you the HLA distribution, okay? Since I managed to skip that one for some reason. Here we go. Okay. So in terms of the HLA distribution, it's important to note that about 40% of the general population has DQ2 or DQ8. Okay, that means 40% of the population is actually at risk of developing celiac disease, even though only about 3% of individuals will actually get it. This is data from the DAISY study in Colorado, where over 31,000 newborns were HLA typed. And, when you look at those, again, who are DQ2 homozygous versus having DQ2 or DQ8, or DQ2 only versus 2 copies of DQ8 versus DQ8 alone, you can see that, the most common genotypes are having either a single copy of DQ2 or a single copy of DQ8. So again, 40% of the population has DQ2 or DQ8, which means that they could potentially develop celiac disease, but that also means 60% of the population actually doesn't have these permissive genotypes. And of course, it really depends on your race and ethnicity, because that really influences how common DQ2 or DQ8 may be for you. Okay, we're going to go back to the next one now. Okay, so there's also pediatric considerations in genotype interpretation, right? you really have to be thoughtful about whether or not we should be doing age-late testing in children. Obviously, there's going to be a certain kind of stigma associated with knowing that you have a higher risk for celiac disease and other autoimmune diseases, and that can certainly affect insurability in the future. And no doubt this produces worry in parents, right? I mean, on the other hand, you may be falsely reassured depending on the quality of the testing, but more oftentimes there tends to be an overinterpretation of a positive test result. Remember, like just because you have a positive DQ2 or DQ8 doesn't mean you automatically have celiac disease. It means that there's a risk. And no doubt, HLA testing can lead to anxiety. We know this from the Teddy study where, uh, newborns are getting HLA testing at birth to look at their potential risk for celiac disease or type 1 diabetes. And there's an initial concern, there's initial increase in worry and anxiety in the parents, but that's not something that's sustained over time. In fact, the parents all have good adaptation over time, and so that degree of worry decreases. But it can also lead to excessive monitoring or possible engaging in behaviors to try to reduce risk, and we've seen that in our studies as well. And finally, there's also economic risk, right? Meaning someone who has permissive HLAs may start to engage in excessive antibody testing. It may lead to unnecessary specialist referrals and frequent follow-up visits. So what's the current landscape of genotype testing? Well, there's two ways that genotype testing can take place, right? Um, there's physician-directed testing, and this is using well-known labs, okay? And there's traditionally higher clinical validity when you're using these labs. And importantly, the results of these tests are going to be integrated into the medical system. But we have to acknowledge that there's consumer-directed testing. And with this, there can be technical variability, especially in the level of detail in the genotyping. And the concerns here are that, like, well, this may not be performed as dedicated age-late typing. For example, when it's done for looking at ancestry, okay, and is not looking at age-late specifically, you may not get that level of detail that you need. And even if you have consumer-directed testing, it still may require confirmation in a standard clinical lab. And really, the implication here is that if you're going to be looking at an expensive celiac disease therapy in the future, if it were available, the level of detail and accuracy would matter much more than the current consumer level testing and reporting that we have right now. And when we look at multiple lab reports, okay, on the genotyping, we see that there's a lot of inconsistencies in the reports, and that really does start to highlight the need to standardize the reporting. So most of these labs kind of give you a bit of a binary report, and they tell you if you're at risk or not at risk. In general, that's all you really need to know. But when we start looking at this in terms of future drug trials or future drug therapies, we're going to need to know, is the patient homozygous or heterozygous for these genes? What are the specific alpha and beta chains? What's the exact full genotype? And then if risk is provided, it may not be contextual. So these are things that we're going to need to find ways to try to standardize. Probably not in the technical standpoint, but more in the reporting. The reporting is really the biggest problem here. And I'll end with this, that, if genetic testing is required for future medical decision making for future drugs, again, we're going to be shifting from this, do I have a genetic risk, to am I eligible for treatment? And there's going to be a lot of questions like, who's going to order the test? And will consumer directed testing be acceptable? Or is that going to need to be repeated with a clinical test by your physician? Are we doing a good enough job currently at communicating disease risk? Are we doing a good enough job at genetic counseling? And how can we handle all of this in a responsible way? And finally, what are the implications of testing on the patient, the child, and the parents? So, thanks for your attention. I'll leave it at that. Appreciate your time.
Thank you, Dr. Liu. Again, a great overview, and we'll have more of this discussion as we go to our panel. Our next speaker is Dr. Amelie Theron, who is going to speak on the HLA genotyping in clinical trials in celiac disease. Dr. Theron is a clinician scientist at the Celiac Center at Beth Israel Deaconess Medical Center and also an assistant professor of medicine at Harvard Medical School. She leads and collaborates in several clinical and translational studies in celiac disease. And today we're going to learn more about clinical trials and HLA genotyping. Dr. Theron, please go ahead.
Thank you so much, Dr. Verma, for the introduction. So let's see if I can advance. Excuse me. Okay, yes. So today I'm going to talk about genotype requirements in current and emerging therapeutic trials, how trial inclusion criteria could influence clinical practice, the risk of genotype misinterpretation in payer coverage decisions, and how to align genotype use across clinical and research setting. So some clinical trials are doing HLA to confirm the diagnosis of celiac disease or just get this additional information for sub-analysis on the drug efficacy. Like Dr. Liu was saying, is the patient homozygous, heterozygous? Would the drug work differently depending on the genotype? And we are using more and more IL-2 as a surrogate marker in clinical trial, and it could help the interpretation to know the HLA typing. And other trials are doing HLA typing because the drug is designed or only studied with specific HLA, notably the DQ2.5. Like Dr. Liu told you, it's 90 to 95% of the population who with celiac disease who have that gene. So it's more attractive for companies to work mostly with that gene first for their therapeutic agents. So this audience already know how gluten causes an immune reaction in celiac disease, but briefly, you have gluten peptides that are not digested by human protease, an increase in intestinal permeability causing higher translocation of the gluten peptide in the mucosa. Those gluten peptides are deamidated either in the lumen or intestinal mucosa by the enzyme tissue transglutaminase. This deamidated peptide has a strong affinity with the HLA groove on the antigen-presenting cell, like you can see on the right of the slide. And this triggered a T cell mediated inflammatory response as well as antibody production. And this slide also shows the different target potential therapies for celiac disease could have. There are agents working in the lumen to sequestrate the gluten or digest it, the glutenase. Others are tight junction modulators or molecules that strengthen the intestinal barrier. There are agents inhibiting the tissue transglutaminase to block the deamidation. Others are modulating the immune response by blocking IL-15, blocking the recruitment of lymphocytes, the OX40 ligands, and other cytokines. And finally, there are agents to block the HLA, so the gluten doesn't attach to the HLA on the APC cell and is not presented to the CD4 T cells. And there are other agents leading to a different processing of the gluten in the antigen-presenting cell. So the immune system does not recognize it as an antigen, so it induces tolerance. So as you see, there are different therapeutics that would or would not involve like that specific like HLA interaction that are currently studied in celiac disease. So these are recent and ongoing clinical trials in celiac disease. Some of them, mostly phase 1, did not include HLA typing in their protocol, in their screening, or we do not have this information. Many of the phase 2 studies included HLA typing in their screening panel, even though their mechanism of action did not involve the antigen-presenting cells. So here we have many immunomodulators, agglutinase, TTG inhibitors, that they all wanted to see which type of HLA their participant had. And of course, if they were not HLA DQ2 or DQ8, they were not eligible for the study. But that was not like part necessarily of the drug mechanism, except for the tolerogenic nanoparticle TAC101. And finally, in the bottom of the slide, there are 3 clinical trials for tolerogenic molecules and 1 for HLA blocker that specifically included only HLA DQ2.5 positive patient and excluded anyone who were DQ8 positive as part of their trial design. And in the preclinical pipeline, we also have, I feel, 4 molecules that, based on their mechanism of action, may also be HLA specific. There is oromucosal immunotherapy. There are tolerogenic molecules, ligands of the aryl hydrocarbon receptor on the APC that will kind of like change the configuration of that APC. Some emotope inducing cytolytic CD4 T cell that will kind of like induce apoptosis of the APC that is presenting the gluten, and some nanomedicine that kind of like mimics the HLA and the gluten to block that presentation. So we can ask ourselves whether we are going towards like precision medicine in the fields of celiac disease. I tell you was mentioning like to determine treatment eligibility. So oncology and cystic fibrosis are great examples where, depending on your genes or mutation on your tumor, you will be eligible to a specific therapy. And in general, the prognosis is improved with these tailored therapies. But it's, however, too soon to tell if molecules acting on the HLA DQ interactions will have better outcomes than the other therapies I showed you that are not HLA specific in celiac disease. And in addition to clinical trials for therapeutics, there are new diagnosis methods that may also be affected by the HLA. We may talk a little bit more about IL-2 during the symposium, but briefly, there is an unmet need to confirm celiac disease diagnosis among individuals who already started a gluten-free diet without prior testing. And IL-2 is a cytokine released by T cells quickly after gluten exposure in people with celiac disease. And there is an IL-2 whole blood assay that exposes the blood cells to gluten peptide in a laboratory tube, and subsequent IL-2 levels are measured. And there was a large study involving patients with celiac disease and controls who looked at the sensitivity and specificity of the IL-2 assay. And it showed a lesser sensitivity in people with HLE-DQ8. However, there were significantly less patients with DQ8 in this cohort, as you can see on the right side of the slide. And they had only one patient that was DQ2.2. I mentioned before that the HLE groups match the gluten peptides. So several gluten peptides that match the HLA have been identified over time, but it's possible that some of the HLA-DQ8 restricted peptide have not been characterized yet. So we're not sure if that test is fully complete for the HLA-DQ8 population. And in general, it's also possible that people with HLA-DQ8 have a lower IL-2 response after a gluten challenge. So one of the sub-studies out of the RESET celiac disease study trial, the NextVax trial, involved to assess the response to a gluten challenge. So they included 295 participants screened for the study. Only 10% were not DQ2.5. That goes with what Dr. Liu told you about, that 90% of the celiac population was DQ2.5 positive. And the patient rapidly had to drink a slurry that had 10 grams of gluten flour, and they checked their serum IL-2 levels at baseline, 2 hours, 4 hours, and 6 hours after having the gluten. And as you can see below, there was a lower IL-2 response in HLA-DQ8 positive patients versus HLA-DQ2.5, with only 52% responders, and the amplitude of the IL-2 elevation was lesser. And in addition to all of that, most of the patients heterozygous were only HLA-DQ8 without any 2.5, 2.27, did not elevate their serum IL-2 after a gluten challenge. So there may be larger future studies looking at IL-2, notably IL-2 whole blood assay, in diverse populations for a non-biopsy diagnosis of celiac disease. IL-2 is being used as a surrogate marker of T cell activation from gluten in several clinical trials. But as HLA may impact the degree of IL-2 production, IL-2 genotyping provides important data to better analyze these results. So this is how this is another way how like knowing the HLA is useful in clinical trials in celiac disease, both to assess the IL-2 response and if we want to develop that IL-2 diagnosis marker for people who started a gluten-free diet without former diagnosis. So how trial inclusion criteria could influence the clinical practice? So it can accelerate trial recruitment. So obtaining HLA in clinical practice may help highly motivated subject knowing upfront if they could be eligible for a specific clinical trial. And as I just mentioned, the eligibility for other potential diagnostic methods. So it's very relevant for individuals already on a gluten-free diet. Also, in general, to assess the risk of having celiac disease, like Dr. Liu mentioned. So to know already like what are their the HLA and would they be potentially available for other diagnosis methods. But HLA typing is generally included in the screening procedures. And again, like Dr. Liu mentioned, if it's a critical eligibility criteria, it's very likely that the sponsor would like to confirm it, especially if it was a home like consumer-based testing. What are the risks of genotype misinterpretation in payer coverage decisions? So genotyping will be key to triage which patient is eligible to which therapy if we have HLA-specific therapies available. I'm worried, however, that if we start having like tests looking only for the present or absence of DQ2.5 or DQ8, there could be eventually a misconception that only these haplotypes are associated by celiac disease by payers. If, for instance, insurance is saying like, oh, we are approving only like DQ2.5 positive patients, and there are some tests that are developed that only look for the DQ2.5. There could be eventually a conception that if you're not DQ2.5 nor DQ8, you don't have celiac disease. But we have those few individuals that are HLA DQ2.2 or DQ7.5 who already who also may have celiac disease and should not be mistaken as not having celiac disease. How to align genotype use across clinical and research setting. Who first? Like I mentioned in clinical, are highly motivated subjects who wants to know their HLA, wants to know ahead of time if they could be eligible for clinical trials, and our patient already on a gluten-free diet without prior testing to look at the risk of having celiac disease, rule out celiac disease if they don't have the permissive haplotype. And again, if IL-2 based diagnostic methods become available and the interpretation varies according to the genotype. And in research, I would say essentially every participant should be genotyped for their HLA to confirm the diagnosis. Does HLA impact the drug effectiveness and a better interpretation of the IL-2 biomarker? And how should we do that genotyping? I totally agree with Dr. Liu about a full genotyping to avoid confusion regarding initial diagnosis if the HLA is DQ2.2 or 7.5 and not DQ2.5 or 8. We don't want a clinical trial participant being told that they don't have celiac disease because the screening test in the clinical trial did not do a full genotype and they missed that the participant was in fact like HLA DQ2.2, and then there's confusion with the patient, their clinical GI, their PCP about like, was it a wrong diagnosis at first, just because the genotype for the inclusion of the clinical trials was not a full genotype, and they missed that they had that lesser frequent but still permissive haplotype for celiac disease. And when should we do those genotype in clinical research settings? So is it too soon for systematic genotyping in clinical care? First, if you have positive celiac serologies and compatible duodenal histology, it's very unlikely that your diagnosis is not celiac disease. There could be costs for patients. And again, clinical trial sponsors may be repeating the test prior to inclusion, especially if it's a critical like data to have with the drug mechanism, like implying, for instance, like an HLA DQ2.5. So the key point of this talk are most clinical trials are performing HLA genotyping, with some drugs being currently exclusively studied among HLA DQ2.5 patients. Obtaining HLA in clinical practice may help highly motivated subjects to know upfront if they could be eligible for specific clinical trials. A full genotyping is preferred to avoid clinician and patient confusions if they're not DQ2.5 or 8. And there are future consideration about like assessing eligibility for specific therapies. If those therapies are successful, goes to phase 3 and are approved for on the market. So thank you very much for your attention.
Thank you so much, Dr. Thieren. Obviously, a great overview, and we'll definitely be touching on some of these points in our panel discussion shortly. Our next speaker is Elena Evans. She will be talking about the HLA-DQ genetic testing, the approaches and considerations. Elena is a PhD student in the Human Genetics program at Vanderbilt University, and she works very closely with the Vanderbilt Celiac Disease Clinic to study the underlying genetics of celiac disease and diagnostic patterns to develop predictive algorithms and clinical decision support tools. So definitely a very important part of our conversation today. So Elena, please go ahead.
Hi, thank you so much for the opportunity to speak today. And as I said, I will be covering approaches and considerations for genetic testing, and I have no disclosures. So kind of an overview, we'll be covering the testing approaches, kind of the clinical and consumer-initiated tests, which were so nicely kind of set up and established in the earlier talks, what's actually being measured in these tests, and how they're reported, and some more considerations for standardization. So in terms of HLA-DQ testing methods, originally it was kind of serology based, so looking at antigen antibody matching, but then in the last couple of decades for HLA-DQ testing for celiac disease, we've moved more into sequencing methods, which are still the methods that are typically used today. And so, honestly, Dr. Liu did a wonderful job breaking down the kind of nuanced differences between the clinical labs and consumer-initiated HLA-DQ testing. They do use slightly different methods, and some examples of the current direct-to-consumer options are gluten ID by Targeted Genomics, which can also be ordered by clinicians, as well as 23andMe. So there are kind of broad approaches to looking at HLA-DQ genetic testing for celiac disease. You can look at sequences, so kind of a longer pattern of genetic variants, or look at what is referred to as a tag SNP, or a single nucleotide polymorphism. So kind of the difference between looking at a letter spelled wrong or spelled differently in a sentence or a word versus looking at the entire word or sentence. And there are kind of differences in what groups or organizations will use different techniques. So the tag SNP-based groups are Gluten ID by Targeted Genomics and 23andMe. And then sequence-based tends to be the kind of more established clinical labs. So LabCorp, Quest, ARUP, and I know Vanderbilt as well also uses what is called a sequence-specific oligonucleotide. So matching this kind of longer DNA pattern. And the way that we're actually able to do testing using these tag SNPs is because of a concept called linkage disequilibrium. And this refers to when alleles or genetic variants are inherited together more often than you would expect by chance. And this is kind of how we can use these variants to tag a larger sequence of genetic information. The closer that variants are, the more likely they are to be inherited together or to be in this disequilibrium. And the HLA region has very strong linkage disequilibrium. Another way I like to think about this, because I am a big fan of sharks, is you often find these little fish following sharks. And so if I was going to try and find a shark in the ocean, I could save myself a lot of time and effort and bait by just trying to find this little remora, because I know it will be on top of this shark. And so that's kind of the tag SNP on top of the shark, or on top of the genetic sequence. So tag SNPs have been validated. These first 3 studies were kind of the revolutionary finding that we could use these actual SNPs instead of looking at these larger sequences. And they rely on this linkage disequilibrium. But I will say that these studies primarily used individuals who are of European ancestry and in European populations. And we really do not have, I would say, like very robust studies on the variation in the HLA region because it is so complicated in terms of how this linkage works. We do know that it varies across populations in terms of where you live, where your ancestry is from. And there have been preliminary studies, including the one listed below, that showed that there was a slight decrease in sensitivity and specificity in Iranian populations for DQ8. So this is just something to bear in mind. The tag SNP-based approaches, those companies all kind of report that they are most applicable to European populations. So something to keep in mind. It does not mean that they are not valid. It's just worth noting. So when it comes to HLA type reporting, this is the kind of large formatting that's decided by an international group of experts, and they update that every so often. And so we kind of have this very large granularity, and especially if you're looking at something like organ transplant. But for celiac disease, we really don't need all of these fields, so we can really limit that down. And so it looks more like this, so kind of a lower resolution than what we would do for organ transplants. So you have the HLA prefix, a hyphen, and the gene, so say DQA1. And then we get the star separator, field one, and then field two separated by a colon. Um, and so one of the reasons that we don't necessarily need all of the levels of granularity, for example, for DQA1, for DQ 2.5, is O5 colon O1 and O5 colon O5 really only differ by one amino acid residue, and studies looking at the molecular biology don't seem to show a significant difference. Whereas for DQB1, for DQ8, we do need that granularity of O3, O2. So as I say, Dr. Lu did a wonderful job of showing this, but just kind of another example of how, even though we refer to them as haplotypes, this can be a really confusing term even among people who study genetics. Because as the kind of word would suggest, haplotype typically refers to as half or something you have two of. But for HLA-DQ haplotypes, they can be in cis or in trans, so on the same or opposite chromosomes. So, for example, if this was my set of chromosome 6, one from my mother, one from my father, and I carried these specific kind of patterns in my DQA1 and DQB1, I could have cis haplotypes of 2.2 and 7.5, and I could also have trans haplotypes of 2.5 and 7.2. So technically, I would have four different haplotypes, which can be very confusing. And molecularly, it does not seem to matter based on the literature whether you have a cis haplotype or a trans haplotype. So definitely something to consider. When it comes to standardization for reporting and interpretation, there is some variation with this, as Dr. Theron alluded to. So there are some reports that do not include DQ 7.5 and or DQ 2.2. And so we can see this is 23andMe and Quest, at least from available reports that we have. And it's probably not limited to these, but those are the ones that we know typically don't actually include these alleles. And so obviously, it is more rare to have celiac disease with these types. But the way I think about it is if celiac disease affects approximately 1% of the population, and then within that, approximately 1 to 5% don't have the DQ 2.5 or 8, that's still 800,000 to 4 million people that would potentially have these types that are not included on some of these testing options. And then may get confused, they may seek out other testing, and it just kind of adds to the overall confusion that surrounds the HLA testing because it is a quite complicated topic. Another thing that varies by lab to a certain extent is risk estimates. So often they are only reported as just saying that you are high risk or no risk or presence or absence of these genotypes or haplotypes. That term is often used interchangeably for HLA-DQ results, especially for celiac disease. And so I think kind of strategizing to have standardized reporting for these risk estimates, and especially to make sure that they are something that can be understood by a broad variety of audiences and not just by people who are kind of experts in this type of testing, is really important, especially in the area of therapeutic or the era of therapeutic intervention that we are currently in and will be in for the foreseeable future. Another consideration is the HLA reporting notation that I showed on the slides earlier. So this may seem like a very small difference, like if you actually include the colon separating the fields, or if you include the 0 in front of the 3. But I think because HLA-DQ testing is already a topic that has so much nuance and has so much kind of complexity, I think maintaining the standardized reporting can be really helpful so that clinicians and patients don't interpret results as different if they're missing, say, like a 0 in front of the 3, or they're missing the colon, and that may instead be like a different result versus just kind of a different notation. And here are some kind of real world examples of some of these tests. So in some cases, we are missing that kind of standardized notation. The example in the middle is really a nice kind of exemplification of how we're maintaining those HLA reporting standardized notation, whereas on the left and the right, we see kind of a large range of missing kind of those colons and different separators that can sometimes just lead to confusion that I think we can fairly easily avoid, as that's not something that's particularly controversial of including a 0 in front of the number or the colon in between the two numbers. and can help lead to some clarity. And this is also another kind of demonstration of the fact that some tests do not report the actual HLA-DQ types. They just say, are you positive or negative for HLA-DQ2 or 2 or 8? And as has been pointed out, I think it's really important to tell patients their actual haplotypes for this because that may come up later. They may need more granular evidence. And I think it's just something that if you're getting that tested, that it is important to give you the actual granular information. And another set of examples of risk reporting, I think having these kind of projections and kind of a visual estimate or kind of a visual idea of the risk can be really helpful, especially because I think that giving like estimated risks, say like 1 in 10, 1 in 7 is helpful, but I think it's really difficult, it can be really difficult at an individual level to really kind of understand what that means for each person. So having some kind of visual for that, as is demonstrated in 2 of these examples, can I think go a long way towards reaching people who do not have as high medical literacy rates, which numerous studies have shown that's very pervasive across North America and beyond. There is some variation in terms of the risk that's reported on these. Some of them are quite similar. So one of the kind of most demonstrable differences on here is DQ8, DQ8, which on gluten ID is shown to be 1 in 100 or about 1% low risk. And then on the lab court report, it is 1 in 12 or 8%. So that's quite a big variation. But the majority of the risk reports are fairly similar. One of the major differences as well is that for DQ 2.2 or DQ 7.5, and DQ 2.2 is sometimes referred to as DQ2 trans. Sometimes these are reported as only being risk haplotypes when they are in the presence of DQ 2.5 or DQ8, or when they are kind of inherited homozygotically. And so I think coming to kind of at least a more consistent understanding of how we're reporting that to patients so that they are not undergoing multiple testing for this is important. And I think giving them the amount of detail that they will be able to take forward into clinical trials is more important than ever. And so some just kind of large conclusions from what we've talked about. HLA-DQ testing measures either tag SNPs or specific sequences, which are just kind of slightly longer than tag SNPs. Tag SNPs have primarily been validated in European populations, so it's something to bear in mind. DQ 7.5 and 2.2 are not always included on testing, and the risk reporting does vary by lab and company, and standardization could definitely improve clarity and interpretability. Thank you so much.
Thank you so much, Elena. A lot of information, and we'll hopefully try and discuss some of this. At this time, I'd like to invite all of our panelists so that we can have a panel discussion. And as people are joining, the panelists are joining, I'd just like to welcome Dr. Shelley Gunn. She is a board-certified pathologist and also founder of Targeted Genomics and serves as a medical director for many different labs and is very knowledgeable in the world of laboratories and HLA. We also have Dr. Haley Zelperberg, who has joined us, who's a gastroenterologist at Cornell Medical Center in New York and is specialized in celiac disease and a special interest in patient outcomes. And finally, but not the least, is Dr. Jonkers, who has joined us from way across. She's an associate professor at the University Medical Center of, I tried to really do on Chat GPT, how to say Groningen, and I don't know if I can really do it, but I tried. Okay. President-elect of ISSCD. There was a lot of learning, but here we are. Research into the genetics and environmental triggers of celiac disease, and her work has paved new pathways for understanding and treating celiac disease. And truly, everyone on this panel here, I think, contributed so much to the knowledge, and I know they definitely contributed to my knowledge. And I'll acknowledge to everyone that I was not excited about being the moderator of this panel, but I am so glad I was forced to do it in a way. Because I've learned so much. So I'm hoping that we'll have a robust discussion. Some of it will be based on what I, as a clinician and a pediatric gastroenterologist, I look at these reports and say, oh my goodness gracious, what do we do with that, right? So we don't know what to do with that. Where do we bring it in? So my first question, actually, I'm going to bring it to Dr. Gunn. What standards are needed for the HLA testing and laboratory reporting to ensure results are interpreted consistently? What do you think a lab should really do as maybe a minimum or somewhere a little more than a minimum?
Well, as a minimum, it's been brought up in this panel multiple times, but to have a complete set of markers is the first step because so many people, I speak from the consumer world, but also physicians are starting to use gluten ID and they want to be able to rule it out. That's really the power of genetic testing. And the way we use it most often, as Dr. Robert pointed out in her discussion, I have to say these genetic talks, all three of them have been spectacular, really nice overviews of what needs to be in the report and what need to be in the report. It needs to be tested. So that's the first thing that I wish all labs would not put a genetic test out there for celiac risk without including all of the markers. And then you have the power of the test to rule out, and then you can also use it as just it's not an emerging biomarker, it's an existing biomarker that we don't use often enough to help us with some of our more difficult cases, especially as Dr. Robert pointed out, when all flattened villi do not equal celiac disease, and it can help us sort that out if the antibodies aren't helpful. So yes, all the markers, let's just start there, and then report them in a way that everybody can understand, including the patients. And I've talked to so many GIs who almost need a Rosetta Stone to they get their lab reports out, and then how do you translate it to the patient? Well, first you have to understand it first. So
So maybe we'll come back if we have time to talk about how do we standardize this across the country with the different labs, because that truly is one of the barriers. You have so many different labs, and then there's 23andMe and whatever else there. So maybe we'll come back to that if we have time.
okay.
Dr. Jonkers, question for you. How do you envision the role of HLA testing changing as we enter an era of genotype-specific therapies? And we talk a lot about precision medicine, but maybe we can talk about the specific therapies first.
Yeah, it's a really good question, and I think the jury is still out. I thought it was very interesting to see that the HLA type is indeed correlated with the IL-2 response. And I think in one particular clinical trial that I know of pertaining Z1227, which is an anti-TG2, oh, not an anti-TG2, but a TG2 inhibitor, that is in fact also shown that the efficacy of that drug is tied to the HLA type. And that was done by doing transcriptomics on biopsies taken from patients treated with the drug, and then stratified on HLA type. And if you're HLA TQ2.5 homozygous, then you seem to need a higher dose of Z1227 to be able to get a full restoration of the biopsy. So to me, that's really interesting because that seems to indicate that you kind of need, based on your HLA type, that you can stratify or adapt the dosage of a potential treatment for celiac disease. And that is, I think, good news for the patients because HLA you can determine very easily. And if that helps to improve your final outcomes, that will be very useful.
Thank you. Dr. Zalberberg, you are a practicing clinical gastroenterologist. How do you counsel your patients? Where do you use this HLA currently, and where will you use once you're done with this day today?
Thank you so much for that question. I think it is interesting because I think HLA genotyping isn't frequently used in like clinical practice. Definitely not when it comes to diagnosis. In a new patient, let's say they have the serology, they have the biopsies. I practice adult medicine, so generally, right, patients have both in the United States in order to really have the diagnosis. Where it comes into play often in my practice, and I think in many others, is in those patients that Dr. Cow mentioned who it's not clear that they have celiac disease. Maybe they had testing done elsewhere. Maybe they were already on a gluten-free diet. And so in those patients, it's often helpful to do an HLA type because if you don't have documents, they're not really sure what their testing showed in the past, they're already on a gluten-free diet, and they don't have that HLA type, then it's very unlikely that they have celiac disease. However, what becomes very confusing is, as we've all mentioned in this panel, is when reporting of the genotyping isn't accurate. And so sometimes patients will come with records of genotyping and it will only say, DQ 2.5 negative or DQ, 8 negative, but what about DQ 2.2? And so it becomes challenging when results aren't accurately reported in a consistent, system. And I think moving forward, I think that would be, something that we should all, strive for. And I think using HLA in that setting, would be helpful and something that I'll continue to do moving forward in my practice.
Well, thank you. Dr. Liu, a question that came through as you were speaking, can a person still have celiac disease in the absence of DQ2 or DQ8? I know that Dr. Zebelberg kind of alluded to that, but I wanted you to have an answer for that question.
Yeah, thanks for that question. I mean, I think that the risk of actually ever getting celiac disease or having celiac disease is extremely low, but certainly nothing is absolute, right? And I think that's the hedging that I have on this is that I'd never want to really make or break a diagnosis based on just a single test like this. And if there's still a lot of questions, you still might want to do due diligence. But I do wonder what other people think about that. Like, how do you actually tell individuals what the risk is when they're HLA-DQ2 or DQ8 negative? I say it's extremely unlikely, but it's not impossible to still develop celiac disease.
Well, we tell them that it is definitely not zero, even if they have none of if low-risk genes, it's a little higher than zero, and then it's close to zero if they have none of the genes. But the statistics are out there, and so never say never, especially in a clinical situation where all of the symptoms, serology, biopsy point to celiac disease. If they don't have those genes, it's still celiac disease. So you're absolutely right. It's not a single test. It's only can be a single test as a rule out, and even then, it doesn't totally rule it out.
So I'm going to switch gears. So thank you for those answers. Switching gears to how do we make this happen? Currently, and there is a comment in our Q&A as well, and rightfully so, that we really don't do much of the genetic testing as we do clinical medicine. Why? And the question is, why do we downplay it so much? Maybe I'll answer it very quickly. Maybe we don't have the knowledge. So maybe that's why we downplay it. But, where do we go from here? So here we are talking about having the genetic testing done. And till today, we are only doing genetic testing in the United States if there is a diagnostic dilemma. So from a clinical standpoint, what do you think would be something, Dr. Thieren, that you would say perhaps you want to change your workflow, or not change your workflow, but are there any thoughts about that?
Well, I mean, it's mostly I totally agree that we need an uniform method, hopefully a uniform lab. And I always discuss with the patient about the downfall of yes, if it's positive, it doesn't mean that you have celiac disease. But yes, with my institution, we try to do it in-house and have a full genotyping at our institution.
And Dr. Liu, from a pediatric standpoint, where do you see this working in your workflow?
Yeah, I mean, I think the question was sort of like, why aren't we using it more? I mean, it can be really useful as an exclusionary tool. 60% of the population is sort of non-permissive for celiac disease, but as a gastroenterologist, I mean, we're not seeing people typically when the question is, am I at risk of celiac disease? We're seeing them whenever they're already antibody positive, right? Or they've got a lot of symptoms. And so you're already thinking that celiac disease is a possibility. So we're not necessarily doing the HLA testing there. If you're thinking about this from a population screening standpoint, like you want to test everybody, then this is where HLA testing could be helpful to exclude 60% of the population. Or from the research standpoint, to exclude those individuals. So I think it's just because of the clinical flow. Like that's not necessarily the question that we're asking at the time to do HLA testing to exclude. The only other thing though is that like HLA testing to use this at the population level for screening would have to be much more inexpensive for that to be worthwhile.
So I guess one of the things you're bringing up is perhaps the cost from a screening standpoint, and then the education for providers, not just the consumer, but also the providers, the clinicians, in terms of how do you interpret a particular test result. You know, you get a test result, you've got to know, are you really looking at the right result or not? But Dr. Liu, you have an interest in surveillance. How about thinking about using genotype to guide your surveillance intensity? Hearing that if you have a double copy homozygous DQ2, there's an intensity. Could you see that as a role for genetic testing to then say if you have that particular double copy or homozygous or something, do you monitor that patient a little bit more? We've been talking a lot about surveillance and we've been talking about therapeutics, but how about we shift gears and think about this in a surveillance standpoint as well?
Yeah, I think so. I mean, we saw like how risk can be stratified based on your genotype. I do want to like really make the point though that like we don't want to overemphasize that risk either, right? Like when we report something like celiac disease, extremely likely, or extreme high risk, I mean, this puts a lot of worry in individuals, and you have to put that in perspective. And so, yeah, somebody who's, for example, DQ2 homozygous, who has a family member with celiac disease, I might, allow screening to take place more frequently over the first 10 years of life as opposed to other people, and that goes to the same with the implicit risk of type 1 diabetes, for example. But I don't want to overstate that risk and cause unnecessary worry. So it's not something I've typically been doing in terms of risk stratification and clinical decision making.
But maybe Dr. Jonkers has something to add. Go ahead.
No, I think Ed is making a really strong point with regards to not worrying patients too much. Even with the HLA DQ2.5 homozygous genotype, your risk is elevated, but it's not, it's still not super high. Uh, Genetic counseling in that case is incredibly important, not just for the children or the parents themselves, but also for when these at-risk people are thinking about getting children themselves. And you do encounter patients that say that they have the HLA gene, and that is a very common saying among patients, but it's clear that they don't really understand what that means, just from saying that. And also that may cause them unnecessary worries, and even may help or deter them from family planning. And that's something that I think is an over exaggeration to a HLA risk, to be honest, and you want to watch out for that, I think.
I completely agree with Iris about that, and especially in a setting where we're talking about having this screening be like universal. And I prefer to see it from the consumer point of view. If people want to know their risk or their children's risk, it's that they have the ability to do that through a well-designed consumer-initiated test. But to do it at the clinic level, I think that would put unnecessary um, anxiety into the picture when maybe it doesn't need to be there. So completely agree. I will say from the consumer perspective, one of the main reasons people are ordering tests are former people who have, or not former people, but people who have been formerly diagnosed with celiac disease and they now have children. They are proactively screening their families, and not from a fear point of view, more of a dietary planning and what do I need to look for in this child? Well, I can actually have some supervision of what their diet is. So that's the number one reason I see people ordering the testing. The second one is people who cannot tolerate the gluten challenge, and they'll go on it for a couple of days and then they haven't not had their genetics done. They get their genetics to make an informed decision about whether to continue with the challenge. So dietary planning more than anxiety is really, I think, a really good way to use this testing. So it could be offered, but not, promoted as something that must be done.
Thank you.
One thing I
And
think is, oh,
go ahead.
sorry.
No,
I was gonna say,
please.
one thing I think is worth noting about that is like one of the major considerations if we did want to do population screening is the wait time to get in to see a genetic counselor is typically quite long already. They're also not necessarily taught a very nuanced version of celiac disease genetics. And so I think that's an area that we would also need a lot of kind of strategizing to really make that possible.
I totally agree. I think that there is so much that needs to be done. I'm going to ask one final question, and hopefully each of our panelists can give me one answer. So it's from Dr. Stahl. What tools do you all recommend for patient education for HLA results? So there's a family who's listening to this. Where should you go? Or there's a clinician who's like, what do I tell them? So who should I start with? Dr. Lu, where do you refer?
I think Elena's point about genetic counselors is really important. We need to learn the right way to do this counseling. We counsel our own way. Dr. Stahl and I are in the same group, right? We do it our own way. Um, so I don't have a great answer for that either. It's I try not to overemphasize the risk, and I still use this for the most part in terms of yes, there's a risk, and no, there's not a risk. And I try to downplay like the degree of risk at this point, because at the individual level, that's less important than at the population level.
Okay. Dr. Zyberman, where do you tell your patients, or if they ask you, if they had a choice, insurance aside, where would you suggest?
Yeah, as we're saying, I'm not sure that there are great resources available that really explain this in depth. And I think that even as part of our panel discussion and putting this together, we all had a lot of questions about what the different HLA types mean. And so I think for the layperson, it would be very confusing even. If there's maybe a website that had this information, or a pamphlet, there could even be more questions. And there isn't generally genetic counseling available for celiac disease. There are counselors at different institutions, but I think they would have a hard time, as Elena mentioned, discussing celiac disease. And so I frequently, speak to my patients, but I find that other gastroenterologists and other primary care doctors, other providers, oftentimes are confused about all of this too. Even if we all learn about this in varying degrees in our training, and it's still a topic of a lot of confusion.
Thank you. Dr. Theron, where do you recommend?
Yeah, so I totally agree that we do not have a good resource that simplifies the HLA education. So it's yes, it's mostly me who explain there are 4 pieces and how because also I would say there are sometimes some doubts that if both parents are not HLA positive and the child is HLA positive, I had some situation that they are kind of a bit asking questions. So yes, it's mostly me, but I totally agree that we should work with patient organizations or other organism to do some more easy education that they could access to.
So never do the parents' HLA and find out it's 2 separate ones, right? Dr. Jonkers, what happens in Europe? Where's the genetic? Where do you suggest people go there in terms of looking for where to get the testing done?
That's a very good question. I'm not a clinician, so I don't typically, ask for these kinds of tests myself, and I don't really do the diagnosis in any way. But I think it's usually done fairly similar to what is done in the United States, in that you request a HLA testing through a clinician. It's not so much individual based that you can go for 23andMe, but it's not something that is routinely done by many people, I would say. So if there is an HLA test being done, then usually it's through a general practitioner or a gastroenterologist or pediatrician that requests them. And I completely agree with the people that went before me in saying that it is a very complicated thing to understand, with the nomenclature being very confusing as well as the whole just the fact that there's two HLAs, that they have to form a heterodimer, and all those things. It's something that you cannot just explain to a lay person without having some extensive understanding of genetics. And so I think in many respects, a specialist, somebody with good background knowledge, is necessary to explain, what it means to be at risk for celiac disease, what it is to be permissive for getting a celiac disease diagnosis based on your HLA type. And I'm not sure how easy it will be to just write a pamphlet to get that done. So yeah, I'm very curious to see how this will develop. Yeah, but I hope it will improve.
I hope so too. And I know that as usual, I'm over time. This is my standard. I can go over time all the time. So, but I do want to thank the panel. All of you have done such an awesome job. Just a couple closing remarks. I think we've all learned that we all need to learn more about the HLA genotype testing. How do we make it happen? We need a lot of education. I think we need education for the providers, we need education for the payers, and we need education for the families. I don't think that everyone can do this. So we do need specific genetic counselors. I think if any gastroenterologist, even in the celiac space, feels that they can counsel patients appropriately looking at the test, I would say I'm going to challenge you, because I don't think it's possible. So I do think there have to be specific people in celiac centers who know this really well. And I would say this would be one of the things that hopefully will come out of this day, is that we need to have more learning and education. And then think about the HLA genotyping, not just from a therapeutic standpoint, but also how, as Dr. Theron talked about with the IL-2, and can we use this from more like a companion to diagnosis and response biomarkers. So I really think we need to think about genetic testing in very different ways. And lastly, I would say there are many other diseases as well that are HLA dependent and are in the market. I learned about medications for uveal melanoma therapy. That was the first FDA-approved therapy which required HLA genotyping as a companion diagnostic, and there's many more as well. So I think we need to learn from other diseases and perhaps spread away from just the TTG itself, and learn more about genetics without increasing the anxiety on the patients or the gastroenterologists. So thank you so much. I learned so much from all of you on this in this particular session. I appreciate each one of you. Thank you so much, and we'll sign off. And everyone should join back at 1:30 Eastern time. So thank you.